Good evening, namaste, adab, and sat sri akal to all our doctors present today with us. We at GastroCare Hetero welcome you all for this webinar. Hetero Healthcare is one of the leading pharmaceutical companies in India. We aim to improve the people's quality of life with our product line and a continuous R&D process. One of the therapies that interest us for more discussion and R&D is EPI in diabetes. And today, with the help of this webinar, we would like to create a platform for all our doctors to share their experiences on this subject and further help in benefiting the patients. Over decades, we have seen that the trend of diabetes demonstrate the speed and direction of evolution of diabetes epidemic. India ranks second in the world, providing shelter to around 17% of world's diabetes population. The prevalence of diagnosed diabetes is as high as 15% in India. Often, diabetes patients are screened for complications like cardiovascular markers, nephropathy, retinopathy, etc. However, EPI in diabetes is often misunderstood with age associated GI issues and left undiagnosed. The prevalence of EPI in diabetes is as high as 50% in type 1 diabetes and 20 to 30% in type 2 diabetes. A myriad of tests for EPI have been developed over the years. However, the choice of which to use still remains unclear. In addition, there is significant confusion over dosing and administration of pancreatic enzymes. EPI in diabetes is thus quite often misunderstood. Today's webinar aims to address on this existing myths, remove the current confusions, and provide us all with a practical guide for the diagnosis and treatment of EPI in diabetes. I take this opportunity to welcome our guest of honor for tonight. We have Dr. Sanjay Tandon with us from Lucknow. Dr. Sanjay Tandon is a fellow of Indian College of Physicians, American College of Physicians, fellow of Royal College of Physicians, fellow of American College of Cardiology, fellow of Indian Society of Cardiology. Dr. Sanjay Tandon is an honorary secretary for UPAP. So we welcome you, Dr. Sanjay Tandon. Along with
Thank you. Yeah. Please go ahead.
yes,
Pooja, go ahead.
yes, sir. So we welcome you today for this discussion, and please enlighten us with your thoughts onto this subject, which is a very common subject, but still often misunderstood and misdiagnosed in cases of diabetes. Welcome, sir.
Thank you for inviting me. And again, since Dr. Puneet is not in picture, we have a very eminent gastroenterologist from Lucknow, Dr. Puneet Mehrotra. We both of us will be discussing about EPI, especially in diabetes. See, what each one of us must, whoever are listening, we all are aware that pancreas is one organ that regulates nutrient digestion and absorption in conjunction with other organs. Now, pancreas is one organ which has a dual characteristic of secreting both having the endocrine power and the exocrine power. The digestion is mediated largely by major pancreatic enzymes, lipase, amylase, and proteases. Reduced secretion of pancreatic enzymes from the pancreas, rapid destruction or inadequate contact between food and enzymes within the intestine results in nutrient maldigestion. And then you can go to slide number 1. Mr. Randall? No. Go further down. Yeah. Go to the introduction part. Just wait here. Yeah. Reduced secretion of pancreatic enzymes on the pancreas, rapid destruction or inadequate contact between the food and enzymes within the intestine results in nutrient maldigestion. This condition is defined as pancreatic exocrine insufficiency, also known as exocrine pancreatic insufficiency. So this is what we are going to discuss today, me and Dr. Puneet. Next slide, please. Next slide. We know that pancreas is about 12 to 15 centimeter long structure. I won't be wasting time in it. Situated in epigastric and left hypochondriac region. It is roughly 60 grams in weight. As I said right in the beginning, next slide please. There are two major functions of pancreas. It has a dual characteristic of having endocrine functions and exocrine functions. Though it's partially endocrine in function, the major function of pancreas is exocrine. But endocrine, though forms the 3 to 4% part of pancreas only, but still has a major role in day-to-day activities and hemostasis of or metabolism in human beings. So the endocrine functions are governed by islets of Langerhans, which have alpha cells 20%, beta cells 75%, and delta cells somatostatin. Besides pancreatic polypeptides being released by the endocrine part. Then in the exocrine part, we have pancreatic juice. As we all know, it consists of bicarbonate, water, amylase, lipase, trypsin, and these three enzymes, along with chymotrypsin and trypsin, they form the major enzymatic bulk which help in digestion besides gallbladder, which is secreting bile. Next slide, please. Next slide, Mr. Randa. So you can find the SNI are being all around surrounded by these islets of Langerhans which secrete the hormone insulin and glucagon. Now, what are the endocrine functions? The alpha cells, which I said there are three major cells in it: alpha cells, beta cells, and delta cells. The alpha cells secrete glucagon, which are responsible for increase the blood glucose level. Similarly, beta cells, they secrete insulin, which are responsible for reducing the blood glucose level. And delta cells secrete somatostatin, which inhibit the secretion of insulin and glucagon, in addition to inhibiting the secretion of growth hormone from the anterior pituitary. This is all we know about the endocrine function of pancreas. Now, coming to the exocrine, next slide, please. And the next slide, please. Next slide. Next slide. The exocrine pancreas secrete pancreatic juice consisting of water, mineral, enzyme, as I said, amylase, lipase, and proteases, and two inactivated enzyme precursors, trypsinogen and chymotrypsinogen. Now, to digest the protein, trypsinogen and chymotrypsinogen are inactive enzymes, precursor, activated by enterokinase to enzyme trypsin and chymotrypsin, which convert polypeptide to tripeptide and dipeptide. Digestion of carbohydrate is aided by amylase, which converts polysaccharide into disaccharide, and digestion of fat, lipase, the main enzyme about which we'll be discussing today, converts fats into fatty acids and glycerol to aid the action of fats, bile salts, and emulsify fats. Next slide, please. Now, coming to symptoms, I think Dr. Puneet, will you like to join in, or do we go ahead with the slides now? Mr. Rajendra?
Can you first finish your presentation, then we can go ahead and discuss it.
That's a long presentation, I suppose. Okay, chalo, let me hurriedly go through it.
Yeah.
Now, once we have to diagnose EPI, how to diagnose, because this is one disease, or this is one entity, not a disease. This is one entity which is usually overlooked, not diagnosed, maybe because of lack of knowledge about this subject, or because of this entity sharing its symptom platform with so many other conditions which we normally see in day-to-day practice. That is why most of the time physicians either are not aware about EPI or they are unable to diagnose this. Maybe I said because of the comorbid conditions which have overlapping symptoms. Now, how to diagnose EPI? Fecal elastase 1 measurements are not effective. I think the diagnosis. First, let us go to the symptoms of EPI. The symptoms of EPI include mild abdominal discomfort, bloating, cramping, and increased flatulence. Now, these symptoms in everyday OPD, all of us are listening, patients coming to us complaining of bloating, cramping, increased flatulence, abdominal discomfort, and you find in so many conditions, maybe because of the medicines that you are using it, because of other conditions which are there like IBS, maybe a symptom of IBD, and so on. Patients with severe insufficiency have steatorrhea. Those patients who have severe EPI, they normally present with steatorrhea, which is loose, greasy, foul-smelling, voluminous stool that are difficult to flush, float or stick to the bowel, and there is considerable weight loss. Now, this steatorrhea and weight loss you don't find normally in early stages of EPI. That is why you normally miss EPI. Develop late in the disease process after there is a loss of 90% of the pancreatic secreting cells. Now, once the exocrine functions go down to 90%, that means the function has been lost by 90%, then only you find steatorrhea and weight loss, because 10% of the enzyme can sufficiently prevent the steatorrhea and weight loss. Now, if it is going beyond that, then only steatorrhea and weight loss is there. So once you find a patient presenting to you with steatorrhea and weight loss, and you think about EPI, that means that the patient is already having a loss of about 80 to 90% of his exocrine pancreatic functions. Next slide, please. Now, this is the most important, though very difficult step in EPI. Now, how to diagnose? Because we don't have diagnostic modalities readily available in our in-house pathologies. Say Lucknow, still you have few now national laboratories which are here, but in a smaller town or B-grade town or C-grade town or a district, there aren't any facilities to diagnose EPI by simple test. The only thing that you can do is best made by combination of history, ruling out other causes of malabsorption, cross-sectional imaging of pancreas, and diagnostic tests. The most practical approach involving testing that is non-invasive, inexpensive, and readily available is not readily available. And second is fecal fat measurement. And third important thing is to estimate the level of fat soluble vitamin measurements. I don't think it's an easy way going ahead as far as the laboratory evaluation for EPI is concerned. You have to be more reliable on your clinical sense, and you have to form a DD and rule out others, and then zero down on EPI. Because finding fecal elastase, I was just checking whether there's only one lab, that too not belonging to Lucknow or UP, that is taking 5,000 rupees and sending it across and giving the results in 3 or 4 days. Fecal fat measurement, again, a very cumbersome process of collecting fecal fat for 3 days. No, neither the patients have time, neither the doctors have that much of time of doing this cumbersome process. Fat soluble vitamin measurements, again, is not handy at every place. But even then, having said that, a fecal elastase 1 level less than 200 microgram per gram is abnormal and commonly used as a cutoff point to diagnose pancreatic exocrine insufficiency. In case you have facility, you do a fecal elastase 1 level. If it is less than 200 gram, it is abnormal. If it is less than 100 gram, it indicates the severity of EPI. Next slide, please. The fecal elastase 1 measurements are not affected by PERT. That means while you are giving a pancreatic enzyme replacement therapy, fecal elastase 1 is not the diagnostic test to be measured every time to assess the progress of the disease, because it is not affected by PERT. Once you are giving pancreatic enzyme, symptom-wise the patient is becoming okay. But if you start measuring कि सब कल तो 200 था, आज 300 हो गया कि नहीं हो गया, 400 हो गया, तो no, because PERT is not affecting fecal elastase. So that is a one-time diagnosis that you diagnose EPI by fecal elastase and then forget about it. Now, patients with severe EPI have elevated level of fecal fat. So you have the symptoms of abdominal bloating, dyspepsia, heaviness, flatulence. You think that the patient may be having EPI. If you have the facility of going ahead with fecal elastase, go ahead. If not, then the other option is to go in for fecal fat estimation. Now, steatorrhea is greater than 7 grams of fat per 100 grams of stool per day. Samples with greater than 14 grams of fat per 100 grams of stool per day is indicative of severe fat malabsorption. The gold standard, as I said right in the beginning, for diagnosis of steatorrhea is 72-hour quantitative measurement of stool fat, but it's very cumbersome and rarely used nowadays. Cross-sectional imaging is indicated in adult patients with new onset steatorrhea and or weight loss in order to obtain a structural evaluation of the pancreas. Because, next slide please. Now, before going to this next slide, let us see what are the causes of EPI. Besides diabetes, which is forming a major chunk, about 13 to 15% prevalence is that of diabetic patients presenting with EPI, and nearly 90% of pancreatogenic diabetes, in case of chronic pancreatitis, are having this EPI. Now, other causes can be IBD, IBS, which can be there. The other important cause for EPI is chronic pancreatitis. Cystic fibrosis, a very important cause. Celiac disease. And these all can present with EPI. Now, we'll be concentrating more today on EPI in diabetes. Next slide, please. As I said, the prevalence is somewhere around 13 to 15% overall. In that, if you do a type 1 or type 2, you find that it is about 38 to 40% in type 1 diabetes and 28 to 13% of patients with type 2 diabetes. Duration of diabetes is one of the risk factors of EPI. Longer the duration, more the chances of developing EPI. Frequency rates were comparable between patients with either type 1 or type 2 diabetes, and type of treatment has no effect on EPI risk in patients with type 2 diabetes. That means which type, either using a SGLT2 or using a DDP4 or using any other OHA, that type of treatment is not going to affect. It is the duration of the treatment, or it is the uncontrolled diabetes with a lot of glycemic variations, a long duration, make the patient more prone for EPI. Next slide, please. What are the clinical consequences of EPI? As I said right in the beginning, the patient has that abdominal bloating, dyspepsia, flatulence, which is always disturbing the patient coming to you. And the moment the patient lands to you, then you start thinking, maybe that the patient is having amoebiasis or simple long-standing history. You take it as IBS. Again, if the patient is presenting to you with symptoms of steatorrhea and weight loss, the first thing that clicks in the mind of a physician, I'm not talking about gastroenterologists, but about the physicians, is the first thing that they say, the most common thing that we encounter in day-to-day practice is tuberculosis. So then we think of it, the patient is not fitting into chronic amoebiasis, IBS, IBD. Then we think on the lines of tuberculosis, that the patient is having weight loss, is having steatorrhea, maybe because of malabsorption. Maybe the patient will start working on the line of tuberculosis. Hardly anyone thinks of EPI. Now, mild to moderate disease, typically there is abdominal discomfort, pain, diarrhea, flatulence. As I said, it can be overlapping with metformin. If the patient is a diabetic using metformin, then that can also lead to abdominal bloating. GLP-1 agonist again can lead to abdominal bloating and distension and dyspepsia. So you have very overlapping symptoms. These are very non-specific symptoms which you can find in so many things because of medicine, because of other conditions of IBD, IBS, chronic amoebiasis, and so on. Pancreatic disease was correlated with factors like age, sex, smoking, BMI, and dietary habits. In patients with EPI, right in the beginning we discussed, due to chronic pancreatitis, there's increased rate of deficiency of fat-soluble vitamins, especially E, D, and K, which can lead to also osteopenia and osteoporosis. Next slide, please. This is again about the symptoms. Again, we have discussed again, they can be because of the drugs, the medicines that you are using. There can be differential diagnosis. You can add celiac disease, you can have SIBO, commonly seen in diabetics. A poor glycemic control, autonomic neuropathy, all can produce these symptoms mild to moderate and severe. Now, if you have severe symptoms like steatorrhea or weight loss, you have to go in for a fecal fat estimation test or fecal elastase if the symptoms are there. And if you diagnose it, then the answer will be dietary counseling, pancreatic enzyme replacement therapy, which normally doesn't click in the mind of the physicians or the treating doctor. And ultimately, the patient somehow lands to people like Dr. Puneet, gastroenterologist, and then they see, though served in a plate after thorough investigation by the physician, that everything has been ruled out. And now the first thing that will click in his mind then will be EPI. Puneet, I think I'm not wrong in that.
Right. That's what happens.
Pathophysiological aspects of EPI in diabetes, I don't think we require much to go into the pathophysiology aspects. But there is one thing very interesting in it, that investigations are performed, a lot of investigations and research has been done why you have EPI in diabetes. You have seen in type 1 also, type 2 also, type 3C, that is pancreatic diabetes. The proposed factors are basically because of diminished trophic effect of insulin. They say, I'll tell you in the second slide, inflammation in diabetes we know, and because of inflammation and the fibrosis of the pancreas. Additionally, diabetic microangiopathy is a complication leading to ischemia in the exocrine pancreas, because that major part of the pancreas is exocrine, and impaired enteropancreatic reflexes due to autonomic neuropathy. There is again an enteropancreatic channel which is going on, which tells you when the food has reached in the intestine via CCK or secretin or vagus nerve, when to secrete the digestive enzyme. That also gets disturbed, leading to EPI. Now, like we have a incretin axis for the control of sugar, here we have an islet acinar axis. As we saw in the first figure, right in the beginning, that there are a lot of these acinis are being overcrowded with all around these islets of Langerhans, which are mainly responsible for insulin and glucagon secretion. The islets surrounding acinar cells are the first cells to get in contact with the islets secretome via capillary network. That means there is a connection, a portal vessel, very intricate capillaries joining, helping the blood to reach from acini to islets and from islets back. So there is a portal system there, like other portal systems that we have. So ideally what happens is, in islets receive an overproportional amount of arterial blood compared with the exocrine. Though the irony is this, that the exocrine forms a major part. Even then, islets receive an overproportional amount of arterial blood. And this in turn goes to the exocrine part via the islet acinar portal vessels. So the God has made another channel. He has supplied more blood to the endocrine part, but from the endocrine part, because with the help of portal services, it is transported to the exocrine part. Due to this local peri-islet insulin levels, because once the insulins are liberated, secreted, so these peri-islet levels have a high insulin level. Now, insulin downregulates the specific receptors in the acinar cells. The beauty is this, the insulin helps in down-regulating its receptors in the acinar cells and upregulates the synthesis of digestive enzymes. Now, the crux is here. The insulin, how insulin is responsible, because here in the acinar cell, it is down-regulating its own receptor cells for the transport of its work, but is up-regulating the synthesis of digestive enzyme. And this is how it helps the exocrine part. Additionally, glucose uptake is increased upon insulin exposure to the acinar cells. Since there is a lot of insulin, so there is a lot of transport of glucose into the acinar cells to help their functions increase. Now, once there is deficiency of insulin, like in type 1, or there is resistance of insulin, acinar atrophy was the most pronounced around insulin deficient islet compared with insulin expressing islets. जहाँ पे islets में जहाँ पे insulin secretion हो रहा था वहाँ पे exocrine functions बढ़िया हो रहे थे because insulin was helping in down regulating its own work and up regulating the synthesis of diastolic enzyme. जहाँ पे इंसुलिन की डेफिशिएंसी थी या रेजिस्टेंस था तो इंसुलिन उतना अच्छा काम कर ही नहीं पा रहा था, तो फिर आइलेट्स अल्टीमेटली एसिना की एट्रोफी होने लग गई, तो एक्सोक्राइन फंक्शंस हैम्पर होने लग गए, लीडिंग टू व्हाट वी वर डिस्कसिंग ऑफ ईपीआई. Besides insulin, endocrine pancreas also produce glucagon, somatostatin, ghrelin, pancreatic PP, and other peptide hormones which are involved in the regulation of islet acinar axis. So it is not that simple. It's a complex process with the help of capillary network, which is helping this endocrine part to help in maintenance of exocrine part. This regulation or deficiency of these hormones in diabetes also contributes to EPI. So this was one axis for this EPI development in diabetes. The second is fibrosis and steatosis. As in diabetes, there is a lot of inflammation, later on leading to fibrosis. And diabetes is also associated with ectopic fat deposition in the pancreas, thereby hampering the exocrine function. Again, there is a loss of exocrine because of fibrosis, steatosis, and thereby producing EPI. And third, you find a lot of inflammatory cells, CD4, CD8, CD11, all aggregating and destroying the exocrine part because of the pan inflammation. Like you find in cases of type 1 diabetes, you have a lot of autoantibodies in type of 1 antibodies, which are actually disturbing the insulin part. Similarly, out here, you have autoantibodies, you have a lot of inflammatory cells, leading to destruction of the exocrine part. So broadly, there are three processes going on. One, because of hampered insulin, the exocrine part is getting hampered. Second, because of white cell inflammation causing destruction of these SNIs. And third, being replaced by fibrosis and steatosis, and thereby decreasing the exocrine part. This is, I think, the broader part of pathophysiology that you should know. So what we did. Now, what is the diagnostic approach? Again, this is what we discussed right in the beginning, that it's not easy to diagnose EPI by means of investigation because you won't find investigating facilities all across India, as 80% of the population living in rural population. So it is very difficult for people to get access to good labs. What to say about good labs? Even in Lucknow, we don't have facilities for all these things. So what to say about smaller areas? So again, a 72-hour fecal fat, if you go by only theory, cholecystokinin secreting the two hormones responsible for secretion of pancreatic enzymes and also the bile. You can do a stimulation test for them, a very cumbersome process. Endoscopic pancreatic function test you can do. I think Dr. Puneet will be telling you later on. Secreting MRCP test. Fecal chylomicron activity also can be assessed, which I don't think any lab in Lucknow is doing it. Fecal elastase, I told you that I could get it hand on only one lab, which was again sending it outside Lucknow. So, though the tests are there, but they are cumbersome, time consuming, which hardly anyone is doing these days. So, you have to be more reliable on your clinical skills. You can try breath test. You have hydrogen breath test for carbohydrate malabsorption, then you have urea breath test, and so on breath test. Different type of breath tests are also being advocated for diagnosis of this EPI. It is often difficult to detect EPI in patients with diabetes in routine clinical practice. Majority of patients are usually asymptomatic in early stages, as we discussed. The classical symptoms of steatorrhea and weight loss only occur in the end. So you have to have a high index of suspicion for diagnosing PI. Number one, you should be aware of this entity. Number one, what is EPI? Then only when the mind knows, only then you can think upon the basis of the clinical symptoms. And you have to form a DD and then rule out all other probable causes where investigating facilities are there, and then ultimately come down on this. And if you still have 100% suspicion it is a case of EPI, go ahead and send the sample for stool elastase 1, test and confirm it. Patient with diabetes often describe symptoms of fatigue and difficulty controlling blood glucose level. There are many causes of diarrhea in diabetic patients, such as small bowel SIBO, we said, diabetic dysautonomia. PEI should be suspected in patients with long-standing type 1, type 2 diabetes. Investigation besides the routine, you have to go in for CBC, electrolytes, liver function, blood glucose to see HbA1c to find the level of dysglycemia, then tissue transglutamine antibodies for other IBD conditions, thyroid function, calcium, vitamin D levels to see the fat soluble vitamins, stool sampling test we have already discussed. Differential diagnosis, as I said right in the beginning, you have to differentiate it. Either if the case is of EPI, and here we are dealing with diabetes, it won't matter whether patient is type 1 SIBO. You have to rule out celiac disease, again an important cause, and the end, these symptoms may be really because of POX, which is very prevalent in our country. So these are certain things where you can have easy tests to rule out celiac disease. You have IgA, you can go in for the cystic fibrosis, you buy the MRCT of lung, then you can have a sweat chloride test for that. So for these where you can find tests, it will be easy if you are still confused. Is this EPI because of this? Then you can go ahead with the battery of tests if available. Prognostic factors in EPI in diabetes, you have to have a very good glycemic control to prevent you from having this EPI. As we have discussed, a very important role of insulin, insulin dependence, elderly age, presence of microangiopathy, and autonomic neuropathy. Management, which is the most important part. I think, Puneet, will you come in the picture because now the main important point starts. PERT, or should I go ahead with the slides first and then you want to discuss?
I think let's finish your presentation, then we can have practical questions discussed between us and the.
Okay. The therapy of EPI is based on both the dietary counseling and administration of exogenous pancreatic enzyme. Now, here lies the treatment part. Now, once you have diagnosed either on the basis of symptoms or by excluding other differential diagnosis or by getting a fecal elastase test or by doing that cumbersome process of 72 hours fecal fat estimation, and you confirm, yes, this is a case of EPI. If it is because of diabetes, you have to have a good glycemic control to prevent it further from aggravating. If it is not because of diabetes, then you have to think of the other causes and you have to treat those causes. The mainstay of EPI treatment in diabetes is pancreatic high fiber diet. Fat aided in symptomatic EPI. Why? Because if the fat is not there, this lipase is very fragile. So if it doesn't have a substrate to work upon, less than 1% of it will remain, otherwise all diminish. So you have to have fat as a substrate where this lipase is going to work. That is why you don't have to restrict fat. Substitution of fat soluble vitamins and other micronutrients might be necessary. What is the characteristic of an ideal PERT preparation? Survive the gastric acid milieu, enteric coating technology to release enzyme at a pH of 5.5. That means the duodenum or lectron, where the digestion will take place. Released in duodenum and mixed along with chyme, enzyme in many microsphere. Contains the correct dose of lipase, which is very important. Gastric acid itself initiates protein digestion in the stomach. GI tract contains more of salivary amylase than pancreatic amylase. In the event of PEI, the concentration of salivary amylase has been shown to increase. Therefore, strict dosage criteria may not be mandatory for amylase and proteases, which is required for lipase. Lipase, as I said, is most vulnerable among the supplemented pancreatic enzyme, with the survival rate as low as 1% of the enzyme during intestinal transit in the absence of substrate, that is fat. And that is why they had said you don't have to restrict fat over in the diet, because if you don't find fat, the substrate is not there, then the lipase will automatically get diminished. A high concentration of lipase in the pancreatic enzyme supplement is mandatory. The ideal dose for is the pancreas is a huge reservoir enzyme. It has been shown that only 10% of the total daily lipase output is required for fat digestion. 90% is the reserve. Therefore, daily dose of at least 20,000 units per meal of lipase is mandatory for fat digestion. Thus, an ideal pancreatic enzyme supplement preparation should be an enteric-coated mini microsphere with at least 20,000 units of lipase. And the optimal action should be achieved by taking the preparation along with immediately after food. So there are two options. First, you start the chewing the food, you take half the dose of what is required, and then once you have nearly finished your food, then you can take the other half dose for better action. For Indian patients, intake along with food provides the best compliance. Since the initial response to EPI or PERT could be erratic, supplementation should usually be started with the higher dose. So we are thinking of 20 to 30,000. This is up to 40,000 with each major meal if required. This could then be titrated up or down. Factors such as size of the patient, size of the meal, and nutrition could also aid in determining the starting and maintenance dose of PERT. Weighing up to 120 kg or so, then the same amount of dose will not be sufficient for that patient. Then to a patient of 40 or 50 kg body weight and going ahead with PERT. Another important aspect is provision of adequate nutrition. Several micronutrients, example vitamin B1, B5, C, zinc, copper, iodine, biotin, and certain folate, do not require pancreatic enzyme for digestion. See, B1 to B5, we have discussed, we will be taking only ADEK, fat soluble. So here they are mentioning from B1 to B5, water soluble, vitamin C, zinc, copper, iodine, biotin, and to certain extent folate, do not require pancreatic enzyme for their digestion and therefore should be supplemented, especially in the presence of feature of malnutrition. Right? These are efficacy studies in diabetes. Safety profile of PERT. PERT is regarded as well tolerated with a few side effects. Adverse events are comparable to those with placebo. Supplemental enzyme acts within the lumen of the intestine and is thus considered an inhibitor, abdominal pain, nausea, vomiting, constipation, and diarrhea. The guidelines, what are they? I think Dr. Puneet will take it over. You have to supplement. We have already discussed. Major part with both the major meals. Please again half the dose while you start it. In the end, EPI is not often considered in assessment of diabetes in routine clinical practice. This is very true. EPI in diabetes is not uncommon as evidence data from the India suggests. We know about 15-17% people are suffering from EPI. In India, fecal elastase test is available in a very few select centers. This is what I was telling you right in the beginning. While the breast test is not available. Therefore, high index of clinical suspicion is prudent. So you have to be based on your differential diagnosis exclusion principle and high level of suspicion about EPI. EPI could be managed adequately with the correct use of PERT, and still if you are not sure, you think you have excluded other causes and you don't have the facility of going in with the investigation, there is no harm in trying PERT. Studies and you find a symptomatic improvement in the patient, and if at all you can go in for a 24-hour or 72-hour fecal fat estimation, you find it is getting reduced, or clinically you find the patient's stool is better, that itself proves that the patient was having EPI and PERT was the right choice. Studies have shown that a pancreatic supplement could have a positive effect on the glycemic status of the diabetes patient also. Not proven yet, but studies have shown this. Guidelines meant for management of EPI and chronic pancreatitis hold good for diabetic patients also. Thank you so much. Randall, thank you. I think we can have all the. We can
Stop sharing the slide.
stop sharing it now.
Yes, I'm stopping.
Yeah.
Pooja, yes. Pooja, can. Pooja, you are mute. Pooja, you are mute.
Thank you so much, Dr. Tandon, for giving all your insights on such a critical topic. Now, I would like to welcome Dr. Puneet Mehrotra. Puneet Mehrotra has a 20 years long experience into clinical and therapeutic endoscopic experience in the city of Nawabs, Lucknow. He is a senior consultant gastroenterologist of Lucknow Gastroenterology and Gynecology Center. Sir has received many awards and recognitions such as J. N. Berry Young Investigator Award at Epicon 1995, Best Paper Award at UPISG Kanpur 97, Best Paper Award at National Conference of Pediatric Gastroenterology at New Delhi 98. Sir has participated in various camps organized by various voluntary organizations. Dr. Puneet Mehrotra has contributed in health awareness through various articles published in various newspapers. Moreover, Doctor has organized seminars for creating awareness amongst clinicians in the city of Lucknow and its periphery. We welcome you, Dr. Puneet Mehrotra, for throwing your clinical aspects and experiences onto this topic of EPI and diabetes. Welcome, sir.
Thank you, Pooja. Thank you very much for the nice introduction. I think Dr. Sanjay has covered beautifully about everything about exocrine pancreatic insufficiency. I think the bottom line of the presentation is that we often miss this diagnosis or we do not diagnose it. That is where the problem lies. And as he rightly mentioned, the availability of the test to diagnose EPI is very, very limited. There is only one or two labs which are doing this fecal elastase and estimation. And we both of us checked with all the labs in the city of Lucknow. We could find only one of them doing it. That too, not doing it here, sending samples to Delhi.
And that too has a exorbitant cost, 5,000.
SGPGI is still doing that coefficient of fat absorption, that is fecal fat estimation, but predominantly for the research purposes, not for the general public, but still they are doing it. So the problem of diagnosing EPI is not based on lab criteria because we don't have enough lab tests readily available to us as a clinicians. I would agree with Dr. Sanjay Tandon that we as clinicians miss this diagnosis, even we as gastroenterologists, in patients of chronic pancreatitis, patients of acute pancreatitis, patients of pancreatic malignancies who come to us with obstructive jaundice, patients who have acute recurrent pancreatitis. All these patients often come to us regularly on a regular basis, and we often do not suspect exocrine pancreatic insufficiency, and we often treat those mild symptoms, abdominal cramps, bloating, fullness, just as a part of IBS-like symptom or part of the disease process as such. And we hardly supplement with any pancreatic enzymes. Most of my patients who are supplemented with pancreatic enzymes are those who have chronic pancreatitis or those with acute recurrent pancreatitis, where there are some structural changes in the pancreatic duct based on an MRCP, and we supplement them with enzymes. These patients often do well. There is enough data to say now that even pancreatic malignancy patients who have enough malnutrition because of malignancy as such, supplementation of pancreatic enzymes in these patients has helped them by increasing their nutritional status and overall morbidity to the tune of 25 to 30%. So we should be well aware that pancreatic enzyme supplement in these patients would be of some benefit. Similarly, in patients of pancreatitis should be a similar situation. The only problem with diabetics is that there are so many other morbidity associated with diabetes, and GI symptoms after long-standing diabetes are very common. You have fatty liver, you have IBS-like symptoms, you have small intestinal bacterial overgrowth, which mimics EPI, almost mimics EPI. Like it has all the symptoms of EPI as a SIBO. So most of us, even Dr. Kandan would agree that most of us treat them with rifaximin or a lactobacillus, and most of the patients would improve for some time. And when they
Yeah.
come again, and they are with the same symptoms. But in lack of tests, we do not supplement with enzymes. But from today's talk from Dr. Sanjay Tandon, I think our index of suspicion should increase. Maybe we should empirically try supplementing with enzymes and see what the benefit is. My only problem, Dr. Tandon, is that even if we supplement these enzymes to these patients, how do we monitor them? How do we come to know that they have improved or they have not improved? What is your thought on that?
I think if we go ahead, Vaneet, with the symptoms, what we were seeing in the patients, if we have a very high level of suspicion in long-standing diabetes and you think that the symptoms may be because of this, then why not try this pancreatic enzyme and give them an optimal dose and see the response as the symptoms are decreasing or not. If the symptom patient is benefiting, then I think we have rightly clinched the diagnosis. And if we have rightly ruled out all other differential diagnosis,
So
that is the crux.
Yeah.
Because if you have not ruled out the differential diagnosis, maybe that the patient is having other problems also, and we are just overlooking it.
So let me ask you a point of question. If you have a diabetic patient in your clinic with abdominal symptoms like bloating, cramps, diarrhea, off and on diarrhea, what investigation will you do first before you put them on pancreatic enzymes? What would you like to do? What would you like to rule out, like before you put them on pancreatic enzymes?
The patient is presenting with a long history of diarrhea or a long history of diabetes. Definitely, I'll go in with a routine test like CBC, ESR, CRP to find the screw. Or there is no history of any specific, like patient giving you a history of taking gluten and then developing these symptoms. So if there are no pointers to any indicative pointer to any other disease, then definitely a stool culture and a blood culture to be, and if he's a diabetic, to rule out SIBO, number one. Stool culture to is having any infection in the intestine leading to this problem. And then fecal elastase, as we discussed, is not an easy job to get it done, and costing somewhere around 5,000 or so. Again, it's not a common man's investigation. So then, if the patient is having dysglycemia, then I'll try definitely anti-emetic dose in such cases, because that's the easily available thing with a PPI definitely, and the patient responds for a longer duration of time, that's okay. If the patient is not responding or is showing only a partial response, then the ideal thing I think will be we should add a pancreatic enzyme. Now, if we have this insight from today's talk, what we are discussing now, what do you think?
My question is that most of the patients who would come to you as a senior consultant must have been seen by many other people around for diabetes. I believe they must have been investigated thoroughly for various other causes of abdominal.
But then you have to think about the probable medicines first. If you are SFT, you have to think about the probable medicine. Maybe the patient is metformin is disturbing him. Maybe the patient is having GLP-1 analog. Or there may be other medicines which are disturbing the GI flora and causing this abdominal distension or diarrhea. And if you have ruled out, number one, the medication is not the cause. If you have ruled out that diabetes is well controlled or not controlled, then you are controlling the diabetes. Then the most likely thing that I would go ahead with is that this is what we normally do. If we think of IBS as the first thing, if the patient is not responding, many times the patients are kept on long antidepressants for these. Sometimes the patient does show benefit with addition of PPI and antispasmodic and antidepressant, but then you see his case sheet. There is a long history going from doctor to doctor. That's the time that you should think of EPI now and treat him on that line and see whether the patient is responding or not. What else do you have in mind?
No, I was thinking that do we have any other lab parameters or other tests which we can do to look for some subtle evidence of
The only thing then you can go by, except for the imaging test that you should go in for to rule out pancreatitis and all, chronic pancreatitis in a case of long-standing uncontrolled diabetes, you have to think about pancreatitis. Then the only thing that you can send the patient is for a fecal fat estimation.
No, what I would think was that maybe when the patient is with you or with me or as a diabetic patient with malnutrition, I would definitely look for doing a hand grip strain, look for a BMI, look for the bone mineral density, like doing a dual absorption X-ray studies.
Go ahead.
Rule out the fat soluble vitamin deficiencies. If you have any of these markers present, then your suspicion becomes strong that you might be dealing with EPI instead of a simple SIBO or a plus IBS-like symptoms in the patient of diabetes.
See, in long-standing IBS also you can have deficiency diseases of many things.
Most of them will not.
IBS presenting with long-standing malabsorption type of picture. So you will find that there is deficiency there, but not to the extent what you find in these cases.
Yeah.
Definitely in these cases, you have to write in the beginning, I said in the slide, you have to look for osteopenia, you have to look for osteoporosis, you have to be vigilant about ADEK, you have to look for the clotting factors or any other thing, easy-bruisability and so on. But normally in OPD, do we see such cases? No.
Normally not.
We don't see neither.
SIBO is the most ruled out because small bacterial growth often presents with these symptoms. SIBO is the one which mimics most with EPI. So if you rule out SIBO in your diabetic patients, then your suspicion becomes strong for an EPI.
Yeah. So how do you rule out the SIBO normally in a case presenting to you?
Normally we do as gastroenterologists do a glucose hydrogen breath test. We do a glucose hydrogen breath test. We give around about standard dose of certain amount of glucose to a fasting patient and measure the hydrogen breath levels for a period of 2 hours. It's a very simple test to do. And once you know that, then you are sure that you're not dealing with SIBO, and then you can go ahead and treat it with an EPI. SIBO is something which can be ruled out easily by a glucose hydrogen breath test.
Full of complete blood count and SIBO. Okay. So once you have ruled out SIBO, then you know the patient is not that of chronic pancreatitis, and if he is having deficiency diseases with the symptoms and uncontrolled diabetes, then you have flinched the diagnosis of EPI.
I have seen quite a few ultrasounds with fatty pancreas. They often
fatty pancreas, yeah. They write fatty and fuzzy.
Fatty and fuzzy pancreas. I think these are also patients which should be evaluated closely for EPI.
Definitely, they should be evaluated for EPI now after this insight that we have gained. Not we, whether you are knowing as a gastroenterologist. The physicians normally were not thinking on these lines. Very less. Most of the time, we think only of IBS, IBD, COX. That's the three things that the physicians normally zeroed on. Hardly anyone is supplementing with pancreatic enzymes.
That is the whole purpose of this webinar, that awareness should be there that pancreatic enzymes have to be key.
This is the time that the patient doctor should have this DD also in mind. If they are getting a long-standing symptoms of these, which we have discussed, if you have a deficiency disease of ADEK, your patient is showing osteoporosis. See, in a long-standing diabetes, a lady or a male, because of the age factor also, you have a lot of things of these. You have osteoporosis, you have osteopenia, a 60-year-old lady coming to you with history of flatulence, this and that. So you have to rule out gallbladder disease also, which is very common in our setting. Every day you see a patient coming with that belching and distension and flatulence, and you find obese lady, uncontrolled diabetes, you find a lot of gallstones. So that again is a very important thing, leading again to chronic pancreatitis gradually and providing this EPI platform.
What do you think? What dosage do you use a pancreatic enzyme in your patients? What dosage would you prefer? Like what dosage and how long?
This is very important. How long? See, if the patient is responding on pancreatic enzyme, say 20,000 or 25,000 or 30,000, whatever you are using with the major meal. Initially, to start with, I think that will be the best idea to go in, because telling the patient to take, there will be no compliance. So you have to think about the Indian patient for compliance also. Most of them are having two major meals. So with two major meals, if you are supplying substantial amount of pancreatic enzymes, then the cost factor is there. They are not that easy. People hardly have money to afford their meals. How to supplement them with pancreatic enzymes?
Yeah.
Then they are getting treatment for the diabetes also. They are getting treatment for other comorbid conditions. That's the irony. So many times you think of the disease, you think of the symptoms on that line, but you cannot, you are handicapped because you cannot supplement them. You have to again be based on those common enzymes that are available in the market, which are very cheap. But that is not going to help the patient. There's not only the diagnosis part, if the implementation part is not there, then what is the fun in diagnosing? You may be diagnosing it rightly, but the patient compliance is not there and the patient is not taking it. So I'll request the pharmaceutical companies, in case they want EPI to be diagnosed more and more by the physician and you want the patient to have benefit of it, you have to cut down on the cost of pancreatic enzymes drastically so that can be easily supplemented to the patients.
I do not know about the role of enzymes in diabetes, but in chronic pancreatitis, the recent literature says that instead of supplementing with very high amount of enzymes, which are expensive tablets, what has been found is that if you supplement them with just good quality antioxidants, the benefit is similar to as much as giving a pancreatic enzyme for a long duration. Because my patient with chronic pancreatitis would need enzyme for a very long duration. For them to be remain pain-free, they would need long duration of enzyme supplementations. So there is a lot of role of antioxidants. Although antioxidants also are equally expensive molecules. They're not
but not to the tune of these.
But
Now,
that is-
only there's one question: how long do we continue? Do we continue lifetime?
I think for pancreatitis, in chronic pain, yes, lifetime.
Lifetime.
But in patients of acute recurrent pancreatitis, if your attacks recurrence or frequency goes down by enzyme supplementation, you can withdraw them over a period of time once the nutrient status improves and the pain frequency improves.
And maybe if you are well controlling your diabetes and you are reducing your weight and you are maintaining a proper hygiene, I think with diabetes also the symptoms of EPI may gradually go, but not in type 1 because you have already lost insulin. There's a lot of fibrosis, there's a lot of steatosis, there's a lot of inflammation. So I think in type 1 also again you have to supplement.
Chronic pancreatitis will be similar. In type 1, the situation is same and chronic.
Similar to what chronic pancreatitis is just. Because the same in cystic fibrosis. It's again a disorder which will not go. So you have to continue to, most of the time the cost factor becomes very important. So again, I think the crux should be on to reduce the price of pancreatic enzymes for more and more people to get benefit out of it. And definitely you have to reduce your weight and maintain a good glycemic control.
But the bottom line is that we should be more aware of exocrine pancreatic insufficiency.
100%. 100%. You people are aware already, but I think the time has come now. The physician forum should realize that EPI is definitely an entity and this should be a part of the DD while thinking about when the patient is coming with these symptoms.
Because we are seeing this in our IBD patients also. We have a lot of patients who have such symptoms. We often treat them
Definitely.
Assuming it could be SIBO only in IBD also. But you never know, they might be having EPI as well.
Definitely.
So we don't test for it. That's what we problem. I think the wider availability of the test would be very important. If you have the
very important. Which till date now, even capital of UP is not having it. What to say about all other cities? I don't think anywhere in UP will be having it.
I had just checked with one of the prominent labs of the city, and they have promised me that in case you are planning to do such tests in your patients, we are willing to procure those kits and start doing it. So I think they are
doing it with the cost of 6,000 to 7,000 rupees, then sir, and then the patient will think we'll have again symptoms of bloating and flatulence with the cost, and the cost of the diagnosis and cost of the treatment. He'll again start telling you कि साहब बहुत ज़्यादा acidity हो रही है, heartburn हो रहा है.
So the only way to convince them the only way to convince would be that apart from your bloating and flatulence, you have nutritional deficiencies also, which will be corrected once you take the enzyme supplementations. Let me ask a final question to you. How do you want the pharmaceutical companies to promote enzymes to clinicians?
think the trust lies in they cut the cost only, then it can be promoted.
Yes.
Because most of the
Take away the
patient
cost.
forum will be very reluctant to need what we face. See, you as a gastroenterologist are getting a tailor-made patient. Most of the time being diagnosed and being served is definitely for a higher precision. See, we are sending the patients to you. Right? For a physician part, you have n number of diseases which a physician is taking care of. The patient is hypothyroid, patient is of renal failure, patient is of uncontrolled diabetes, patient is having metabolic complications, patient is having dilated cardiomyopathy, and for each you are adding a medicine. The cost of the prescription goes so high. The beauty lies in the Indian physician that we see all different aspects of medicine, which no other country is doing it. No other major cities are doing it. You have to go to a gastroenterologist, you have to go to endocrinologist, you have to go to a cardiologist, you have to go to a nephrologist for treatment of the patient. So we are dealing with all the multi-specialties in one go. The cost of the prescription is so high that you think about adding another burden to the patient. It becomes a very cumbersome process for us.
Do you find any difference in the gender also? Like you find more females having EPI as compared to male, or is it similar? Like as far as I'm concerned, GI
I
it's similar.
think
Diabetes, I'm not.
definitely there is a preponderance more in females because of diabetes, because of the per se nature in females that more of IBS is there because of so many stressful conditions at home. So you find a more of IBS-like symptoms in females than in males. Because most of the time males are going out earning throughout the day, so they are busy with it.
Okay.
Female part 80% are there in the home, busy with the household chores, and then they get depressed, and a lot of IBS is there.
So there is another question which I think we have discussed this, that should we start directly with pancreatic enzyme supplementation after seeing clinical symptoms, or we should rule out other causes before we put them on enzyme supplement. I think we have discussed that.
Yeah, you have discussed. I think it will be very pertinent to rule out the major causes first and then add on before going in for the investigation. If the investigation facility is not there, add there, see the response. If he is responding, you are not doing any harm to the patient.
I think the other question was that do we taper down the dose of pancreatic enzymes depending on the symptomatic relief, or we continue on the same dose? As a GI,
you have to answer that.
As a GI patient with chronic pancreatitis, what we do is that we look for symptoms why we have started that. Most of the time, we start these patients on enzymes because of one, their features of exocrine pancreatic insufficiency, plus they have predominantly pain as a feature. And once you put them on enzymes, their pain frequency decreases, severity decreases, and EPI symptoms improve. We usually start with 25,000, go up to 40,000. Once we find that they are doing better, we cut down and go back to 25,000. Initially thrice a day with breakfast, lunch, and dinner. Then we come to lunch and dinner. So we gradually do taper it off, but most of the time we are not able to take it off completely. But the role of antioxidants, we can always switch from enzymes to antioxidants over a period of time.
Very, very nicely dealt with this question. And this was very important, how to de-escalate and escalate pancreatic enzymes.
There's a question about particles, like smaller size of the particle of pancreatic enzymes. I think
size of the particle.
Smaller particle size of the pancreatic enzyme, does it make any difference?
Like with any nanotechnology, the nanotechnology definitely works more. So like you have nanotechnologies for everything, the size definitely will work in favor of better diffusion, better absorption, better, and because the pharmacokinetics will improve, the pharmacodynamics should improve. This is what I think.
Sir, what do you do? In my practice, I would add a PPI along with pancreatic enzyme always. Always I would use a PPI along with pancreatic enzyme. What would you prefer?
Only PPI is the integral part of the prescription of everyone. Only PPI is the integral part. Though we know what complications can be there because of long-standing PPIs. But even then, PPI still forms a major part of the chunk of the prescription for every clinician.
Yeah.
So if the patient is not, if we know that the patient is that of EPI and we are supplementing only with pancreatic enzymes, I think the symptoms should go. So there is no need of PPI. If the patient is not responding on proper treatment of this pancreatic enzyme, then the idea should be to add a PPI and see that the response increases.
I think that's what it is. It should be this way. Because whatever the data says that in case you find that the response to pancreatic enzymes is not there, you add PPI to see that response improves. But I think in clinical practice, what we see that most of our patients anyway are on PPI. So most of the time, the lack of
number of reasons for adding a PPI.
they have a lot of PPI.
They're already on PPI. The next thing that you have to do is add, vice versa. You have to add a pancreatic enzyme to the PPI existing.
Most of the time it is
not the vice versa.
I agree. I agree. That's how it happens. Practically, this is what it happens. You add pancreatic enzyme over PPI, not pancreatic enzyme before. That's what the problem is. Any other?
I think you have covered every part, Puneet, very nicely. You have covered every part. When to go ahead with the PPI, when not to go ahead with the PPI, when to add a pancreatic enzyme, when to taper, when to escalate, rule out the comorbid conditions. And I think we have covered every part.
Yeah, I think that's what it is. I think the bottom line continues to be same, that your index of suspicion should be high. Despite the non-availability of the test, your clinical sense and clinical acumen, your biochemical parameters should suggest whether this patient needs EPI, needs PERT. In case needs PERT, then should be supplemented for adequate duration to assess the response of the treatment. And if you find that the response is good, continue it for some time. Failure most of the time will be because of poor compliance. It is not because the drug.
Very important. Which is normally there with everything. You find a lot of patients with uncontrolled diabetes because of poor compliance. Hypertension, poor compliance. So this is irony that we see in day-to-day practice.
I think the only thing
compliance has to be very important for anything.
It's true for every
listen.
It's true for every walk of life.
Yeah, definitely.
Whether it is exercise, whether it is work, whether it is medicine, everything.
You have to be disciplined in life. Otherwise, then there's always a problem. You have to be disciplined. As far as anything, if you are controlling your diabetes and you are not disciplined, then there are a lot of complications. You know what acute complications, chronic complications of any disease. So the patient has to realize that he is suffering from this, and whatever Dr. Puneet or Dr. Tandon or any other physician or clinician is doing is to give them benefit. Now, I cannot go to every patient to tell them, "Bhaiya, tumhe dawa khani thi khao, ye karo, tumne fit test nahi karaya." You have to realize that you are suffering from that disease and you have been rightly diagnosed and now the treatment is available. Go ahead and take it. So that I think we can finish it off if there are no other questions.
The final question would be, how do you assess the final word would be, how do you assess the response and how do you assess the failure of treatment? Suppose you have started your patient on EPI.
Assess the response will be,
how would you go about it?
If you ask me, then the assessment of response will definitely will be on the basis of symptoms, or if you have the facility of getting a fecal fat estimation done, which normally we don't have. It has to be totally clinical. And if the patient is not responding, then either the diagnosis was wrong, or the compliance was bad, or you need a PPI, as you rightly said. And if after adding PPI and you see that the compliance is there and he is taking adequate dose, which was prescribed, double the dose. If the patient is not even benefiting with that, then I think your diagnosis is wrong. You have to think about other comorbid conditions, or probably the medicine history is to be taken.
What you do in diabetic patients, I'm not sure, but in chronic pancreatitis, you would give them a duration of about 4 weeks of enzyme supplementation, see whether the pain frequency and symptoms decrease. If they decrease, we are sure we are dealing with it. In case they don't, then we think of compliance and other causes. So what you do in diabetics, you give it for 4 weeks or longer than
Say 4 to 6 weeks is a very long standing. You will give another 2 weeks and see if the patient has to respond because of EPI, will start responding in 2 weeks' time if all other parameters are normal.
And there's one more question coming up, that what is the role of uncoated pancreatic enzymes? Is there any role of uncoated pancreatic enzymes?
But definitely, see, if the enzyme is getting liberated in the duodenum all over down, it is going to help you, because if it is getting liberated in the stomach, then the chances of getting destroyed is there. What do you say?
I think there is hardly any role of uncoated pancreatic enzymes now with the technology available. There is no role of uncoated pancreatic enzyme.
You have to go in with a coated enzyme.
The
There's
volume
no other way.
lipase which is required may not reach the desired place to help in function. So I don't think there is any role of uncoated pancreatic enzymes anymore, apart from just being a placebo sort of thing for gases and flatulence.
Definitely.
I think
I think you have done full justice to the topic. Both of us are exhausted, working since morning. It's night time now. I'm having the hunger pangs. Let's switch it off.
I would request that before
Otherwise, you will start having symptoms of EPI now. Dyspepsia, bloating, and everything. It has been a long day today.
I would close by requesting Pooja to let us know she is a marketing guy for this company, and what does she want to say about the comparison of this molecule, their own molecule, with the research molecule available in the market. Does she have any comparison to it? Can she tell us the difference, why hetero is better than the other?
Definitely.
If she has anything to say about it. I think that is what all of us would be interested. Why should we write hetero?
Definitely. Why should we write this molecule and why not that molecule? Is there any basic difference or it is just a marketing strategy?
Yeah, just
Uh, Well, sir, firstly, I would like to extend a heartful of thanks to both of you for making this discussion so fruitful and full of knowledge and enthusiasm, I would say. And on behalf of entire Hetero Healthcare team, I would like to thank all our valued doctors whose participation has made our webinar and this evening such meaningful and eventful. Now, your continued patronage and confidence in our products inspires us to extend the best of services. And also from marketing side, I would like to say that we as a company would like to stay connected with all of you via such webinars, forums, and of course, physical meetings on further discussion for this topic. Well, Dr. Puneet Mehrotra has insisted me so much to talk about my product better than the other competitors. So, sir, definitely our sales team will be visiting to you. As this forum is strictly scientific, so I may not make it more commercial, but definitely PanMed has its own study which we have done versus the innovator competitor onto dissolution parameter and the particle size, which will be discussed in length by our team. Our team members will be shortly providing you the excerpt for today's webinar and as well as more information on our product PanMed, sir. So that was from my side. Thank you. Shubh Ratri, Shabak Khair, and good night.
Thank you. Thank you so much. Try to
Thank
cut
you.
down on the price of your tablets.
Definitely, sir. That is one more USP which definitely our people will be coming to you with.
Okay.
Right.
Thank you. Thank you, Puneet.
Thank you, sir. Thank you so much.
Thank you, Randa.
Thank you very much, sir. Thank you very much.
Thank you. Thank you. Good night.
Thank you, gentlemen. Thank you.